लॉग इन कर दो यार। डॉक्टर अरुण प्लीज लॉग इन। दोनों लॉग इन कर लो प्लीज, बिकॉज डॉक्टर बाजवा विल मेक यू हैव टू मेक यू को होस्ट। हाँ, या प्लीज, या प्लीज।
So it is live on the YouTube now. So they're joining.
Yeah, they're joining.
Mhm. So whatever we are deliberating, it's basically from the our practitioner, private practitioner booklet, na?
Yes.
Yeah.
Yeah.
We have to make it very popular because I think during these deliberations over the next 3-4 months, we may emerge with many more modifications in that particular advisories, so that they become more refined. This is the best way going forward with the deliberation on those already published material. I think during discussion, so Dr. Pankaj, I advise you what happens when you see the recording of this on the YouTube, you accumulate the extra points which are not there in those advisories. You just note down, or you get a help from someone to note down those points. So that in the next GC meeting, you can put up those points that these are the additional points which have been given by the expert from the field. So we can incorporate those points into those advisories. This is the best way to going forward rather than going sending on the review, getting something like that. No? On the
Good, good.
phase we get, those points are very essential. We can always add them up in those. So I think this is where the book will also get popular, and we can get further modifications and revisions also. As well as with the changing times, we can get many more new things also in the advisories.
Yeah.
Anyway, I think they will be joining. In the meanwhile, I think we should not waste time. It's 6
Yeah.
or 6.
You can
So
start.
we should start the session officially. So welcome everyone to this private practitioners forum. So idea of this practitioner forum is to have discussions openly about the various practice things going on in India across the nation and different zones, different states. So the idea of putting the practitioners guidelines and advisories into the discussion is to see how we really see the changing times and how we improve our practice, how to improve the altogether clinical scenario, the patient safety, the benefits of the anesthesiologist. So many factors are there. I think every chapter of the book is basically highlighting the various advantages of those books. So Dr. Arun, where I joined, Dr. Arun, welcome. So you are also making your co-host, and Dr. Pranav is left, I think only. So the sequence of the speaker will be, I think, Dr. Vikas Nair will be the first one.
Yeah.
Yeah.
And then Dr. Manisha Katikar, madam. Then after
Yes.
that, Dr. Arun Mehra, and then Dr. Pranav Gupta, na?
Yeah.
Okay. So I think without wasting time, I hand over the stage to Dr. Pankaj to start the proceedings with the first speaker.
Good evening, all the practitioners in the country. The idea of having these webinars is we are trying to get to know the problems which we have discussed and interacted in the first 5 webinars of each zone. And it was in Patna that we came out with these guidelines, which we rightly mentioned as position statements for anesthesiologists in practice in the country. At Patna in Isakon, it was unfurled at the inaugural ceremony. And since then, we have been trying to propagate the idea of improving the work culture and improving the work standards and the ethics all over the country. The idea of having these webinars was came forward by Dr. Diwatiya sir, who mentioned as the academic chairman that we should have more discussion about this. So maybe if everything is fine with this book, it is great. And this is the book, if you all can see, which has been unfurled at Patna. The soft copy is available, which if you can just send me an email, I can forward the soft copy to you. We have printed around 1,000 copies, of which about 800 to 850 are already been distributed. But whenever we can possible, we will try to distribute the remaining copies also. I have a few copies still with me. Coming to today's discussion, I feel our first speaker is Dr. Vikas Nair. Basically, all the people who worked towards making the booklet is whom I have tried to incorporate in this in series of webinars. I feel around 3 webinars we will have on this booklet. So we can discuss and come to know the problems or fallacies or maybe how we can upgrade ourselves in the future for the betterment of private practitioners in the country. So I feel Dr. Vikas Nair will be the first opening batsman, and I'll request sir to start sharing his screen, and he'll be talking basically on medical legal implications and why pre-op examination and documentation is essential in today's practice. If you all realize in private practice today, like even in my, I remember even in the city of Nasik, for 20 years, most of us were not writing down notes or documenting whatever we were doing. But today, for the last 15 years, all of us are religiously doing it, and this is what we're trying to propagate all over the country. In a survey which I had done about 2 years back, I came to know that only about 50 to 60% of anesthesiologists was actually putting down their notes. Believe me, when you have a medical legal case against you, your notes and documentation is the only thing which is going to help you to save yourself. In fact, in the recent discussion incident that happened in Calcutta, the notes that were returned were confiscated on the fifth or sixth day by the CBI. So after that, the anesthesiologist could not do anything. So we don't know what notes they have put down. So these things are very, very important in today's practice. The documentation that you do. Managing the patient is one thing, but documentation has become as important as managing the patient. So I feel it's very, very important that all practitioners should be putting in proper documents for whatever they are doing in the operation theater. So over to you, Dr. Vikas Nair, please.
Yeah, good evening, everyone. At the outset, let me thank Dr. Bajwa, Dr. Pankaj Gupta for giving me this opportunity to speak a few lines on the significance of the position statements, the preoperative evaluation, and the importance of documentation. Can you all see my
Yes,
screen?
sir. Make it full screen. Make it full screen, sir.
Yeah, now?
Perfect, sir.
So let us go with what is a position statement. Now, a position statement is a written statement from an organization like what we have done that discusses a contemporary clinical problem and suggests an established and agreed upon approach to the problem. What happens here is that the association chooses a few experts or selects a few experts, asks them to go through various evidences, various practices, then agree upon to a particular common thing, and then it will be discussed again and we'll come back to you again, that, like Dr. Bajwa has said. So that is what is a position statement. Now, why is it important and what is its role? It is important to guide anesthesiologists across the country. Recommendation supports sound clinical judgments and decision making, but it does not supersede it. So if the anesthetist feels that at a particular moment, this is what I should do, even though the judgment says something different, but I have strong reasons to believe that this is what I should do, then the judgments, the recommendations would not supersede it. It is also a good way of policy development so that the government health policy makers would look up to this document to develop new policy whenever they think of developing a policy. It also is a good way of education and training for the young trainees, the young graduates. It also tells us more about patient safety, and because it comes out from an organization, a big organization like ISA, there is credibility and authority when other organizations or the general people or the lay people see. What is the objective of this? It is to standardize anesthesia practice and optimize working conditions in the operation theater and non-operating room anesthesia for the safe conduct of anesthesia and satisfactory patient experience. Now, many a times there is a confusion whether a position statement means the same as guidelines, means the same as consensus statement, or is it something different? What is it that usually we are told about guidelines, or recommendations, but we have not very often heard about this position statement. So guidelines basically is a framework for action on a topic. It is usually based on evidence and it goes in a algorithm sort of a way. For example, recommendations given by the Difficult Airway Society. If you cannot ventilate, then do step number 1, step number 2. If you cannot ventilate, intubate, then do the next steps, etc., etc. While a position statement states an official stance on a debatable issue, and it usually represents the group's viewpoints, which may or may not be fully supported by strong evidence. It's not that it is not supported by strong evidence, but the evidence may not be as strong as what goes for the guidelines. Now, guidelines usually are algorithm based, as I said before, and it usually advises how to. So, if this doesn't happen, go to this. If that doesn't happen, go to step B. While position statement generally means it says what we believe as an association. Okay. What is the medical legal implications of this position statement? What happens? So a position statement can be considered as a benchmark for the standard of care, because this has been thought, debated, it has gone through various evidences, discussed and deliberated amongst various experts in the organization, and then presented. So it is a benchmark for the standard of care in a particular situation, and a significant deviation can be seen as a breach of duty. It has to be significant. However, as I said, if the deviation is little pertaining to the situation on hand, and if you have a good explanation to let know of why there was this deviation, then you are fine. The next thing I've been asked is to talk about the pre-anesthetic evaluation. Now, is the pre-anesthetic evaluation important? Of course, it is very important. What is a pre-anesthetic evaluation? It is a process of clinical assessment that precedes the delivery of anesthesia for surgical and non-surgical procedures. And like everything, this too also has its own purpose. Number one is it is to assess known and diagnose unknown comorbidities. Many times you find that a patient who has never been tested, has never been examined by a doctor before, comes up with recent onset diabetes, hypertension, and then you diagnose and you treat accordingly. The next is to stratify risk. Like many classifications, Goldman Caldera classification is one. Once you stratify the risk, and then you have to optimize the risk before you proceed for. All these are important because you cannot directly take a patient up for surgery without optimizing the patient. The next is to make a specific plan for anesthesia and, if required, alterations in patient management. For example, if a patient of severe COPD or bronchiectasis comes to you, you would obviously like to optimize the patient and prefer to do this under regional anesthesia. And another important thing is, once you have made a plan, after examining the patient, after going through the history, the various investigations, then you decide a plan and then you take an informed consent from the patient. What is the medical legal significance? It is a very significant medical legally, because these days, the first point of complaint by any complainant against any anesthesiologist in the last few years that I have been noting, the first thing is that there was no pre-anesthetic evaluation by the anesthetist. None from the hospital has seen this patient before the patient was wheeled into the surgery. So our association says, or our position statement says, that it is mandatory to do a pre-anesthetic evaluation before anesthesia at least 24 hours prior. The next question will be asked is, sometimes as private practitioners, we, especially patients of ASA 1 and 2, sometimes we see just before the surgery. It is ideal to see at least 24 hours prior, but if you have seen just before the surgery 15 minutes, 30 minutes, you do a detailed examination, take history, go through the investigation, mention all that in a separate PAE or a PAC paper where all this is mentioned, and also mention the plan that you have chosen to do anesthesia. So on the paper, there should be even the plan mentioned. That will significantly diminish your liabilities. These are a few case reports which I found while searching through the literature. The first one is Subbaiah versus Union of India here. This was a hernia surgery which unfortunately went wrong. So among the various points which made up the judgment, one of them was a pre-anesthetic evaluation is mandatory protocol to any surgery. The second one, I have put short forms purposely. This is PN versus K Hospital. In this, a 27-year-old young man had a fractured femur, was shifted from a small nursing home to a tertiary hospital in a bigger town with a little low saturation. At the hospital, he found that his ABG was hypoxic, his PO2 was 53. He was doubted to have fat embolism, ERDS, etc. He was ventilated. But he was posted for the surgery the next day for interlocking femur surgery. Surgery was done. He was ventilated, but unfortunately, the patient succumbed to his injuries 6 days later on. Again, this went up to the National Commission. Amongst various points, the presiding member mentioned that there was no pre-anesthetic checkup done by the anesthesiologist, which is an act of omission. And the surgeon was over-enthusiastic and did the surgery in spite of the patient not being so fit to undergo surgery, which is an act of commission, and both were penalized. The next which I found was Srimati P versus V hospital, in which the patient was admitted, and again here there was no pre-anesthetic evaluation done. Coming to the next, which is on documentation. Now, a documentation is a record of a patient's interaction with a healthcare provider, and it includes pre-anesthetic sheet, appropriate investigation, records, consent, and anything which is concerned with a patient is a documentation. So what is a documentation? Anything written, printed, or in digital form is documentation. And it is relied on as a record of proof for authorized persons, and it is a vital part of professional practice. One important thing, as private anesthetists, we run from one nursing home to the other, and we think, as Dr. Pankaj Gupta said, we hardly used to document things maybe 10 years, 15 years back, but now that is not the case. The whole atmosphere, everybody is all medico-legally aware, the patients. So it is better that all of us do proper documentation, because in the court of law, if it was not documented, it was not done. You cannot say, I had done and I forgot to write, or this is understood, this has to be done, so I have not written. That is not done. If it was not documented, it was not done. So it is important that you document everything. So an excellence in medical documentation reflects and creates excellence in medical care. Good medical records tends to deliver good quality medical care, and this is the best defense against allegations of negligence and malpractice. So what are good medical records? Good medical records are records which are correct. That means you have written the notes against the correct patient, the correct side has been confirmed, and the correct surgery you have mentioned. It has to be clear. So we always find that many of the times our doctors write notes which are not very legible. So that is a big no-no. Or a printed copy would be much better. It has to be comprehensive. So you may feel that I can write some things in brief. So the court would appreciate if you write everything in a little more details, and why you chose this particular technique, or why you gave this particular injections, etc. And it has to be chronological. That is, it should be one following the other. Events occurring at 9 o'clock, then 9:15, 9:30, etc. It cannot be jumbled up. And then finally, it has to be contemporaneous. Contemporaneous means you should write down as things happen and not later on. So these are the 5 important things for a good medical record, and good medical records translate into good medical documents. This is very important. The palest ink is better than the strongest memory. You may feel that I have good memories, I can recite after maybe 1 year, 2 years, but one should understand that most of the cases comes up for hearing after 8 years, 10 years, 15, sometimes 20 years. So however strong your memory may be, you may not remember everything, and the judge would also question you about that. Importance of documentation. So functions of medical documentation, it provides all the information about a specific patient in a nutshell, so that me, if I'm not there, the next doctor who is on call or who is in the hospital would know everything, whatever has been done during the intra-op, pre-op, etc. And a strong evidence of administration of standard medical care. So documentation is strong evidence that I have administered standard medical care. The most important thing or an equally important thing is about medical billing, because if you have not documented a particular procedure, so it is understood that you have not done it. It is taken that you have not done it. But in your mind, you said, no, I have done this procedure, though I have forgotten to write it. You cannot bill for that procedure. If you bill for that procedure, then you can be called a cheat or a fraud. And neglecting to document important details can lead to adverse patient outcomes and malpractice suits. So this is the importance of documentation. It is, as everybody knows, it can be presented as evidence in court, best thing to defend against malpractice. And in some cases like road traffic accidents where compensation is determined by what the surgeon or we have mentioned laceration here, fracture in the lower limbs, upper limbs, etc. Because each entitles different compensation. So important things while writing medical notes. Number one is recording date and time of examination. This is very important. Most of us would record dates but forget to write down the time of examination. Then, as said before, legible handwriting. Another important thing is avoid alterations, abbreviations. And in one of the judgments by a consumer court, it was said that preferable that one person takes the consent with the same pen, consent on separate paper, continuation sheet should be numbered, and keep copies of all reports, the blood reports, the X-ray reports, the discharge report, the transfer report, and on discharge, take receipt of documents being handed over. Also, record refusal or failure or unwillingness or delay to start treatment. And sometimes the patient insists that they would purchase drugs from their own pharma. And if it is substandard, you have to mention that, and also mention if patients are on self-medication. Record all important events. So if the patient has misbehaved sometimes in the hospital with anybody, be it an anesthetist, surgeon or anything, then it is better if the apology for misconduct is taken in writing and you preserve that with medical records. And record patient's return request. Sometimes the patient says, no, I don't want spinal or I don't want a block. Then it is better that we write down that the patient, we had offered spinal, but the patient refused to take spinal. So when documenting, spell the words correctly. Correct your mistakes with sense and legality. So never use whitener. When you use whitener, the court always feels that this is a doctored document. Never scratch out. Draw a line through the mistake and initial above the scratched out line so that it is understood that this was a mistake on our part while writing and this is what actually it is. Examples of poor documentation: missing critical information, like you are not mentioned vital signs, allergies, medication details, inconsistent or unclear entries, incorrect date and time. So to conclude, an excellent documentation is an excellent defense. A poor documentation is a poor defense, and no documentation is no defense. We are closely absorbed by everyone. So it is very important that we do proper documentation, proper preoperative evaluation, and generally follow the guidelines that our association has made for us. Thank you very much.
Thank you, Dr. Nair. That was a brilliant compilation of what our position statement is all about. It's good that you highlighted a few things, like the difference between position statement and guidelines. See, the initial document we came out in 2017 was mentioning the word guidelines, but we realized that now ETCO2 is compulsory. There are so many cases which have gone against the anesthesiologist because they have not used ETCO2, so it was straight away considered as negligence. That's why we tried to change the label from guidelines to position statement to safeguard our own interests. Because
Yes.
we understand that ETCO2 was a very big thing debated at all the national groups. that, how can you make it compulsory? We are in a very poor setup, but still we want to do laparoscopy. Or those, so that's why just to safeguard the interest, we thought that we'll, have the name of position statement. One thing about PAE is I understand practitioners are busy, but the recent 2022 guidelines say you can use telemedicine. You can even use the video call to examine your patient preoperatively in case of an emergency, or if you are unable to go because of being stuck up in the OT for a previous case. Also, the chronology of events that Dr. Nair rightfully mentioned, it's very important that the surgeon and the anesthesiologist have the same timing for the notes. There have been cases where the surgeon has mentioned a different timing and anesthesiologist has mentioned a different timing. So invariably, such cases go against you. Thank you, sir. Thanks a lot for a beautiful talk.
Thank you.
Our next talk is on Dr. Manisha Katikar. Actually, when we were making this position statement, we came across the WHO, WPSA guidelines little later on. And I was happy to note that most of things that we had already covered had already been taken care of. So I hand over the stage to Dr. Katikar, who requires no introduction to the National ISA, and she'll be talking on her how our position statement as updated as what WFSA has recommended. Over to you, madam. Unmute yourself, madam. Yes.
Thank you so much, sir. Respected Honorary Secretary Dr. Bajwa and my GC colleagues who have joined for this webinar and all other ISA members. A very good evening to you all. The topic that has been allotted to me, WHO WFSA International Standards for Safe Anesthesia Practice, is a very important topic because we will be comparing our ISA position statements along with these guidelines or the standards which has been laid down by WHO and WFSA together. And at the end, we will realize at the end of my talk, we will realize that how our ISA position statements are very important as far as our anesthesia practice in India is concerned. So these international standards for safe anesthesia practice were developed on behalf of WFSA and WHO. And these standards, they have mentioned that they are applicable to all the anesthesia providers throughout the world. So they have given some highly recommended standards, which include continuous presence of a trained and vigilant anesthesiologist, continuous monitoring of tissue oxygenation and perfusion and clinical observation and a pulse oximeter, intermittent monitoring of blood pressure, confirmation of correct placement of endotracheal tube either by auscultation or by end-tidal CO2, use of WHO's safe surgery checklist, and system for transfer of a care at the end of an anesthetic. So these are so what called as highly recommended or mandatory guidelines. And now if you compare them, see, they have also given these in the form of table. So if you compare them with our ISA positions, you will know that even we have included everything in our ISA position statements for private practicing anesthesiologists. In this guidelines, the WHO, WFSA have also included preoperative area and post-anesthesia recovery room, and have suggested that there should be a dedicated space for both preoperative area as well as post-anesthesia recovery room. Our ISA position statements mention specifically that there are some highly recommended standards that has to be practiced by all anesthesiologists all over India. They include pipe gas supply, continuous supply of oxygen via cylinders, pipeline for anesthesia machine workstations with hypoxic guard safety mechanism, nitrous oxide or air supply either by pipeline or cylinders. One emergency oxygen cylinder should be mounted on an anesthesia machine and the spanner should be there available. The tilting OT table, working suction machine with all the connectors, suction tubings and suction catheters of appropriate sizes, AMBU bag, multi-parameter monitors which include measurement of pulse ox, ECG and NIBP. Use of closed circuit is mandatory for all laparoscopic surgeries, and monitoring of VTCO2 is highly recommended as it improves patient safety features. Temperature monitoring is recommended for children and geriatric patients. Defibrillator again is highly recommended. Working laryngoscope with all sizes of blades and Miller blade for pediatric patients. oral and nasal airways, all sizes, intubating stillates, Magill's forceps, endotracheal tubes, supraglottic airway devices, eye gel, peripherous venous cannulas, spinal needles, epidural sets, three-way connectors and extension tubings of required lengths, IV sets, microdrip sets, blood transfusion sets, scissors, ampoule cutter, torch, thermometer, syringe pump, infusion pumps, nebulization machine. If you suspect a difficult airway, highly recommended are intubating Wuji cricothyroidometer set, 14 or 16 gauge needle, recommended intubating LMA, video laryngoscope. A warmer option has been indicated as an optional and post-operative care where vital parameters can be documented and oxygen and resuscitation equipment should be readily available. WHO and WFSA has given some standards for monitoring of the patient, which already have been mentioned in ISA positional statements. WHO, WFSA have also given monitoring standards for drugs and IV fluids, and our ISA position statements also include various drugs in our for the use in the operation theater. So they include various sedatives, opioids, NSAIDs, intravenous anesthetics, muscle relaxants, reversal agents, various antiemetics, anticholinergics, inhalational agents, local anesthetics, IV fluids, sympathomimetics, vasodilators, beta blockers. All this drug list is available in our book of ISA position statement. Antiarrhythmics, electrolytes, steroids, bronchodilators, nebulizers, diuretics, certain surgery-specific drugs like for obstetric anesthesia and other surgeries, intralipid 20% whenever blocks are performed, adequate number of protective lead aprons and thyroid guards, especially when X-ray and CAM is used and when finder light. The another important aspect of WHO WFSS standards and our anesthesia practices in India are concerned is the use of surgical safety checklist. WHO has published this surgical safety checklist in 2008 in order to undergo or to increase the awareness of risk of patients or the patient's safety undergoing surgery. We are talking about patient safety day in and day out. So a simple procedure what they have mentioned and what we also mentioned in our position statement is to use this checklist, surgical safety checklist in our day-to-day practice. The checklist serves to remind the surgical team of important items that should be performed before and after the surgical procedure in order to avoid the adverse effects such as surgical site infections or retained instruments. It is one of the affordable and sustainable tools for reducing deaths following surgery, especially that has been mentioned in WFSA records in low and social and middle income countries. I am a fan of Atul Gawande and have read almost all his books. He is a co-founder for the mission Safe Surgery, Save Lives. So he describes the influence of this checklist that are in development of the WHO surgical safety checklist in his book that has been written in the year 2009, the Checklist Manifesto. I'm sure most of you must have read this book. So in particular, government appraised the impact of pilot checklists in mitigating the aviation disasters. And he has specially mentioned that do not skip important steps in procedure, especially in surgical stressful environment and in high-risk situations, and this should be followed routinely in our anesthesia practice. In January 2007, an international consultation meeting was held on the second Global Patient Safety Challenge System, called as the Safe Surgery, Safe Lives, and they have mentioned only 3 goals for the use of WHO surgical safety checklist. That is, it should be simple, it should be widely applicable, and it should be measurable. The checklist places 19 items which are spaced into 3 phases of surgical procedure. The first is sign-in, that is before induction of anesthesia when the patient is still conscious. Then time out when the surgeon is present before skin incision, and then sign out depending upon the Joint Commission's universal protocol. So in order to avoid the ambiguity in determining and documenting each step, the WHO recommends that there should be one clinical person, usually a circulating nurse, in charge of making each item of the checklist. So this is the surgical safety checklist, which includes sign-in before induction of anesthesia, time out before skin incision, and sign out, that is before patient leaves the operation theater. So let's see these various parameters of this surgical safety checklist one by one. Sign in, that is before induction of anesthesia. We must confirm that has the patient has confirmed his identity, site procedure, is the site marked, is the anesthesia machine and medication checklist has been done, is the pulse oximeter is on the patient, and confirm that whether it is functioning. Does the patient have a known drug allergy? Does the patient have a difficult airway or a aspiration list? And how much is the expected blood loss? Is there a risk of blood loss more than 500 ml or more than 7 ml per kg for a pediatric patient? All these parameters have some rationale. This is because we know so many cases where wrong site, wrong patient, and wrong procedure errors have been already documented in the and have been already published. So every item has some kind of rationale that has been already published, and we must know all these rationales when we are asking the specific questions to the patient. Timeout is before skin incision, should confirm all team members that they have introduced themselves and their role and by their name also. Confirm name of the patient, procedure, and where the incision will be marked. It is also important to note that whether antibiotic prophylaxis has been given within the last 60 minutes or the last 1 hour. We must know whether there are any critical events for the surgical team, whether they are the routine steps or there are any non-routine steps, how long the case will take, and what will be the anticipated blood loss, whether there are any critical events that are anticipated by the anesthesiologist, whether there are any critical events for the nursing staff, especially about the sterility, is it confirmed? All the equipments or the surgical instruments have been confirmed, and it is also essential to display all the imaging, the X-rays or the CT scans for that particular surgical procedures. Again, all these parameters or all these items have specific rationales, and therefore they have been, should be, all of us must know these rationales, and they have been included in our ISA position statements too. The third is the sign out before the patient leaves the operation room. The nurse who is monitoring or who is checking this, making this surgical checklist, verbally confirms the name of the procedure, complete name of the patient, instrument, sponge and needle counts, special labeling. She should read aloud the specimen labels, including the patient name, and whether there were any equipment problems during the surgical procedures, that has to be discussed. The surgeon, anesthesiologist, and nurses must discuss the key concerns during the recovery and the management of that patient in that particular situation, depending upon the surgical case scenario. So again, the sign out has important rationale, and that is why we must confirm. This is a very simple surgical checklist that we must follow. All of us must follow in our day-to-day anesthesia practice. What was the purpose of this surgical safety checklist? And a safe surgery, save lives groups, they conducted a study and they found that there was a significant decrease in the complication rate as well as death rate when they started using this surgical checklist. So many subsequent studies were done after that, and they have shown improvement in the outcomes and in the death rate as well as complication rate and in various safety measurements. So these studies, all of these studies report improvement in safety culture, better decision making and team coordination, openness about knowledge gaps, and improved team cohesion. So the topic today was WHO, WSA international standards for safe anesthesia practice. Are we updated? So here, this is the important aspect. Are we updated? Yes. As far as the documentation is concerned, ISA is definitely updated. We have recently updated in October, Dr. Gupta has mentioned that in October 2024, we have again updated our private practitioners guidelines, included everything in that, but then all of us need to implement this in our day-to-day practice, and this implementation is very important. So the answer is updation has been done already. Implementation is the most important thing that is remaining, and it should be done at all the levels starting from by every anesthesiologist, starting from corporate hospitals to the rural areas. And I'm sure if we do that, the safety features, the self anesthesia practice, which is our aim, which we will definitely we will be able to achieve that. Thank you so much for this opportunity.
Excellent, excellent, Manisha madam. Could not be better, I feel. You have rightfully compared what we are trying to do at National ISA, and I feel no one could have done a better job than what you have done. What Madam rightfully mentioned, that as anesthesiologist is also responsible in case the surgeon operates on the wrong side. It is all these problems that we face in practice can easily be taken care of if everyone follows the checklist. The WHO checklist is wonderful, whether you have any accreditation of any association or not. Make it a point to use the WHO checklist in every operation theater before every surgery, and believe me, most of the complications you will not face in your life. Thank you, thank you, thanks a lot, madam. I feel the next talk will be by Dr. Arun Mehra. We'll be talking on basically a preoperative questionnaire. See, we have tried to make a lot of questionnaires so that a patient declaration is as important as the history taken by the anesthesiologist or by the assistant in the hospital that the patient gets admitted for a surgery. There have been instances where the patient's insurance, obviously no one declares that he may be an occasional alcoholic, but in the history taking, it was unfortunately mentioned by the anesthesiologist that the patient takes occasional alcohol. Believe me that the uh, the insurance company refused to uh, accept the claim, and that patient has filed a case against the surgeon. Your anesthetist has written that I'm an occasional alcoholic, and now my case is not being filed. So now the poor surgeon is fighting the case for the mistake of the anesthesiologist. So these things have become very important in today's practice. So what we came out with an idea was we'll have a patient declaration. Let the patient declare whether he's an occasional alcoholic or not.
Condition
And then we will, and then after that we will have the
analysis by
questionnaire
the
to be filled in by the assistant anesthesiologist or the medical officer or whoever is doing it. Over to you, Dr. Arun Mehra. Please unmute yourself, sir, and please share your screen.
Thank you, Dr. Pankaj, and I must thank Professor Bajwa and the entire ISA team for giving me this opportunity. And I must compliment both the previous speakers for their excellent presentations. And I must ask for your forgiveness because I have a sore throat right now for the last 2-3 days. Just a minute. Let me just share screen. Just a second. Dr. Pankaj, can you just tell me?
Just share the screen. Na? There is a green icon at the bottom.
Yeah, I've pressed that. Now,
Your PowerPoint is open.
I'm opening it.
No, keep that open first. First,
Okay.
open it.
Okay. Just a second.
Or you can do one thing. You mail the.
I have mailed it to you. I'll start, and whoever can put it up first we'll use it. I have mailed it to you.
Okay.
Here we are. Yeah. Okay, I've got it. Now I'll go back to here. Host tools, share screen. Has it? I can't see it.
Sir, keep it open on your desktop. First, keep it open on your desktop.
Okay,
Yeah,
I'll do it for you, sir.
Thank you so much, Dr. Pankaj.
Yeah. This is the first screen, right?
Right.
First slide.
Thank you.
Please go
ahead. Good evening, everybody. As our two eminent speakers have pointed out, medico-legal issues have become a major problem now. But that is one of the reasons, I'll not say that is the reason, but one of the reasons for a good preoperative assessment and evaluation. And our guidelines committee has made a revised set of evaluation criteria for our anesthesia friends. Now, what we must remember is that what we have created applies to everybody, but at the same time, it is usually the ones who are alone in some remote clinic or some remote nursing home, working alone, who get into trouble often, either because of lack of facilities or because they do not have the, shall we say, proper assistance and everybody. Given that situation, it's especially important for them. Dr. Pankaj, let me see if, just a second. Just a second. Just a minute. It's open on my desktop. Let me try share screen.
Dr. Arun, you stop sharing first, then you download, then you again share.
It's downloaded, sir. It's everything is there.
Then you just close this window.
I'll let Dr.
Clo-
Pankaj
clo-
do it for me. Okay,
Okay, Pankaj is sharing. Okay, fine.
fine.
Okay.
Now, so what are the requirement needs for assessment? Identify potential risks and create a safe and effective anesthesia plan. Patient safety optimization. This is all ethical issue and of course the legal part of it. Now, this includes, we all know what it includes. I don't have to go into this. We have all been doing it from PG days. Now, there are a few things you have to tell the patient when he comes for PAC. Bring all medical records, bring all previous test results that are available, bring medications being taken, contact details of family physician, if there is one, and even before coming for PAC, nail polish and such things should be removed. Now, guidelines and recommendations from the ISA. We will consider these under three headings: pre-anesthetic patient declaration, as Dr. Pankaj has just pointed out, so that the patient cannot later claim that he said this and he said that. Pre-anesthetic consultation and of course the pre-anesthetic assessment. Now, coming to the patient declaration. Before taking the history, we should ask the patient what medical conditions he already knows. We must have the name of the patient, age, gender, weight, height, medical history, and of course the name of the surgeon, the admission number, and all these things should be there. Now, this is all available in the guidebook. Soft copies are being sent to everybody. So I'll not go into very much detail here. Just ask about chronic conditions, especially headache, seizures, vertigo, loss of balance. This is something that many of us miss. Then BP, of course, is something we all ask. Diabetes, kidney disease, liver disease, tuberculosis, asthma. And there can be any number of things, of course. You have to ask about cardiac conditions specifically because in this age, Indians have too many cardiac problems. Heart disease, diabetes, and obesity are three things to which we are genetically more prone. Then, of course, breathlessness while walking. We all like to do the breath holding test and all that. Heartburn, this basically has to do with your GI problems. Now, history of previous surgery or anesthesia. Anesthesia need not necessarily mean anesthesia for some surgical procedure. It could have been anesthesia simply for some stitch. Supposing somebody gets an injury and needs stitching. So if the patient knows the details or any complications, then one very important thing, I'm going to come to this later again. Do you have concerns about anesthesia? This is during the discussion with the patient. Have you or your blood relatives, genetically related people had problems with anesthesia. And of course, allergies, steroids in the last 6 months, been admitted to hospital. And now a very important aspect has come up, which is COVID. Now, apart from allergies, of course, we have to ask about alcohol also and tobacco. Do you have bleeding problems? This is particularly important for us. Blood transfusion history, alcohol, smoking, tobacco, loose teeth. We all know that jaw assessment and neck assessment and teeth assessment is very important for us. Hearing aids, again, this is because these are electronic devices which we may or may not like in the OT. And in the case of female patients, pregnancy. Then coming to the history must be from all angles. The kind of history that we were taught in the final year of MBBS. Don't think anything is not important enough. Present illness, history of past illness, family history, we've covered this. Socio-economic history. Supposing you have a patient who comes from an area where Cox disease is very prevalent, then of course, there is always a possibility that the cough the patient may have may be due to that. Dietary habits, there are different concerns for people with different diets, addictions, known allergies, past anesthesia complications, surgery or complications. Now again, here during the actual consultation, the first part, mind you, was the patient's own declaration, and that should be in the history. That should be in the history. What am I saying? Sorry, I mean in the patient's own history, own handwriting preferably. And it should be in the patient's own, whatever the patient says, and the patient must sign it. Now, history of general medical conditions, we all know that. Medications, significant illnesses, surgeries, or hospitalizations. Again, COVID has become an important factor here. History of previous anesthesia, cardiovascular system conditions, as I mentioned earlier.
Sir, we are not able to see the slides. Can
I'm
you
sorry,
share?
where?
Yeah, we are still seeing the
The email.
mail on.
The email, I think,
Oh.
Dr. Mehra, you are able to see because you are seeing in your own computer, but
Oh.
I think,
screen sharing.
Dr. Pankaj, can you then share it, please?
Oh, I thought it was being shown, I thought.
No,
Now?
sir. No, sir.
Oh.
Sorry.
Mm,
Sir, we are
Now?
seeing the email only. Your computer email only we are seeing.
Oh, okay. Mm, Okay, my screen share got paused. I don't know why.
Okay, let me try again. I have got, I have opened it up, share screen, but it's not being shared on the,
Okay, let's see now.
no, not getting it.
Okay, I'll sharing it again.
Hello, Pankaj sir. Pankaj
Yeah.
Gupta sir. Hello.
Yeah,
I'm Dr.
is it?
Manoj Kumar.
Yeah. Can you see me now?
Now we can see,
Yes,
sir. Now
yes,
we can
now
see.
we
Yeah,
can
we can
see.
see now.
Okay.
Dr.
I feel
Pankaj, can we just go back a few slides because they were not visible? I'll quickly rush
that's
through.
okay. That's okay. We have you can still go through. We can see the printed, no problem. Go ahead only. Move ahead.
Okay.
Please go
Now,
ahead.
history of allergies, sensitivities, and known allergies and everything we have to, including in the case of India, also the herbal remedies. And somebody is taking Ayurvedic, somebody is taking Unani, somebody is taking homeopathy. Then social history, as I told you just now, a patient coming from an area where, say, tuberculosis is prevalent, another might be coming from an area where there is iodine deficiency and might have problems with the thyroid gland and all that. Recreational use. These are things that are more and more catching up with the new generation now. Of course, alcohol and tobacco are already there. Family medical history, we have discussed this earlier also. History of GI symptoms, kidney, urinary, and liver function. Dr. Pankaj, can we go a slide back? Yeah,
Allergies, yeah.
yeah. And medical history, and then of course in the case of female patients, pregnancy history. Can I have the next slide, please? Yes.
Sir,
Now
can you
this-
do full screen, sir?
Yeah, that would be very good. All this is actually available in the form, in the booklet that we have brought out. So we all know the standard things we have to ask: pulse, BP, temperature, everything,
Yeah, yeah.
BMI,
Good, next.
condition, nourishment, obesity, everything. I don't have to read through all of
Yeah,
it.
this also we have.
Yeah, then examination.
Examination.
As I said, consciousness level. Now, this can be an issue because you might have an unconscious or a drowsy patient. If you supposing have a patient who has some, say, intestinal obstruction or something, it's not at all necessary that that patient might be fully conscious. Vital signs you have to see. This is, of course, most critical in anesthesia. General physical examination. Nothing should be left out. There should not be an attitude of, we have seen the heart and the lungs and that's enough. No, you have to really assess the abdomen, assess everything, neurological status, systemic examination. Mouth opening, teeth, all that is, of course, the very basis of what we really proceed for. Now, laboratory tests, I will not go into details here because they are different for different age groups. They are different for different comorbidities. They are different for different types of surgery, expected duration of surgery, and the level of the hospital and institution. So some hospitals may not have certain facilities. If they are an absolute must, you must get them done from somewhere else. And blood transfusion, again, under laboratory, it's very important. Now, discussion with the patient. What is the reason for the surgery, reason for the anesthesia, potential risks and complications? Now, additional risks, if they exist, must be explained. And that is something you will come out with only after a thorough history and examination. Now, you must explain the different tests, why they are being done. You must explain why you have reached a particular anesthesia plan and why you feel that is suitable for the patient. But you must give the patient the alternatives. And if the patient wants something else, then you have to explain what are the risks and complications of those. And if the patient is still adamant, then of course you have to get the patient to sign that the patient wants this. And you must explain to every patient that any kind of anesthesia may have to be converted into GA at any time. So we have to take all of the. Now, informed consent. I am sure most of you will know, rather all of you will know what is the informed consent. Informed consent includes risks and complications. Informed consent means alternate plans also. Now, the surgeon too has to take an informed consent. Very important aspect here is in a language the patient can understand. Obviously, a person who is, say, an IT professional and another person who is working at your home as a domestic help, they will need different levels and they will need different languages also. And one absolutely crucial thing here is the chance to ask questions. The patient must sign that he or she has been given the chance to ask questions and all the different queries he or she had have been answered. And of course, then finally, in your consent, you have to have everybody's signature, anesthesiologist, surgeon, patient, relative, witness, and anesthesiologist should also be signing on the surgeon's consent form. Makes things easier for everybody. So basically, we have brought out these guidelines. I just wanted to emphasize what are some of the things, and you can see them in your guideline book, which will be presented to you as an electronic copy by Dr. Pankaj, and try to stick to them as much as possible. Apart from, of course, like Dr. Manisha said, we have to think of the checklist also. By the way, I'll mention one thing. Read Dr. Atul Gavande's books, not just the checklist manifesto, read Being Mortal, and he's really a wonderful writer. So you should definitely read that.
Thank you, sir. Thank you, sir. That was good for a nice presentation. I feel the consent we'll be covering again in the next talk, maybe in the next month. Thank you, sir. Thanks for the presentation. And I invite Dr. Pranav Gupta to start screen sharing, please. He'll be talking on what is new in preoperative investigations and optimization for each surgery. Usually we see that a blanket of investigations is done for almost all patients. But in the recent, there have been papers and discussed in the IJA also, where there are new guidelines which have come up. So over to you, Dr. Pranav Gupta. You can start screen sharing.
Good evening, everyone. Today, I'll be talking about preoperative investigations, and I've been started also working in a medical college, and just a second. So today I will be talking about what is new in preoperative investigation, and my lecture is basically based on clinical practice guidelines that was published in 2022 in May IJA journal, and a lot of effort was taken to publish these guidelines and to make these guidelines. It was the vision of Dr. Bala Bhaskar sir and a core committee of 7 members, and the president and secretary of ISA were in the core committee. Then there was an expert committee, and then there were research questions, literature, systemic review, meta-analysis, and finally the guidelines were made about preoperative investigations. The core committee of ISA guidelines had a very prominent anesthesiologists from all over the country, including our editor, Dr. Rakesh Garg, and significant anesthesiologist, and the expert community also had significant, well-known, educated anesthesiologists from all over the country. And then there were extensive Zoom meeting between the experts in the various groups. Also, telephonic and WhatsApp conversations were there. Biostatisticians, the 13 Zoom meetings were done. Core committee 63 Zoom meetings were done. So the point was that a lot of effort was taken, and no stone was unturned to reach to these preoperative investigation guidelines. There were 10 research questions, and the search was for words for identifying literature. There was a grade protocol, grading of recommendations, assessment, development, and evaluation that was used for systemic review, and the 3-step Delphi method was used, which was used for preoperative investigation. So the main purpose of these guidelines were that the routine preoperative investigations are defined as those tests which may influence the perioperative anesthesia management. So only those tests which will actually influence the perioperative anesthesia management were included in the test, and they should be able to change the outcome in the patients for elective surgeries. So the surgeries were divided into minor, intermediate, and major, and then these were the research words that were used for the analysis and systemic review. And now there was some inclusion and exclusion criteria. The inclusion criteria were ASA grade 1 and 2 patients, those who were scheduled for elective surgeries, and ASA grade 3 patients, those studies where they were constituting only less than 5% of the total study population were also included, and the studies where population included ASA grade 1 and 2, but and higher also, but majorly the outcome was separate for ASA 1 and 2 patients. Exclusion criteria include studies that did not mention ASA grading, where the cost factor was a major reason, and those involving only cardiovascular, thoracic surgery, neurosurgery, and transplant surgeries. And the published guidelines, narrative reviews, editorials, opinions were excluded from the our study. The recommendations for according to the study are like see complete blood count should be done in all minor, intermediate, and major surgeries. Recommendation second was that creatinine is not recommended for minor surgeries, while it is recommended for intermediate and major surgeries. The preoperative sodium and potassium is not recommended for minor, intermediate, and major surgeries, and because that were not actually changing the outcome or our decision for the surgery. Preoperative liver function was not suggested for minor and intermediate surgeries, but it was suggested for major surgeries in 4B. In recommendation 5, the coagulation profile was not suggested for minor, intermediate, and major surgeries. And similarly, the non-diabetic patients, blood glucose estimation is not suggested for minor, intermediate, and major surgeries. In non-cardiac patients, the 12-lead ECG is suggested at the age of 45 years and above in the recommendation 75 7A, means for when they go for minor or intermediate surgeries. In 12-lead ECG is suggested in all patients undergoing major surgeries. In 8A, the recommendation chest X-ray was not suggested for minor surgeries, and it was recommended for patients undergoing intermediate and major surgeries. And routine perioperative ultrasound for the airway assessment is not suggested. I will come to the summary of it so that we can actually summarize it and remember it. Like complete blood count, this green is recommended. And also, this is the validity time of the previous investigation done. So, complete blood count, if it is done within 2 months, and also the renal function and liver function test within 2 months, that is any blood investigation we accept for 2 months, and ECG and X-ray we accept for 12 months. So the complete blood count is required for minor, intermediate, and major surgeries. Renal function, and in renal function, serum creatinine is important. So it was found that creatinine is the most important. Some people do urea, we should not do urea, but creatinine is important, and creatinine is required for intermediate and major surgeries. LFT is required for major surgeries, and ECG is required for all patients above 45 years in minor, intermediate, and major surgeries, while chest X-ray is recommended only for intermediate and major surgeries in patients above 50 years. And these investigations are not like if the patient requires investigation because of his surgery or because of his disease, then the patient will be subjected to those investigations. But these are the minimum investigation to be done in non-diabetic ASA grade 1 and 2 patients prior to elective surgeries. So thank you, and I've kept it short. Thank you, sir. Pankaj sir.
Thank you, Dr. Pranav. That was a very short and to the point presentation. But that is what we have tried to do in our booklet. If you go through our booklet, there are about 4 sections, 11 annexures, and about 5 appendices. Each one is very important, which I'll try to modify it and try to make it in a downloadable form from our website or from the net. And I feel the talks are over. If anyone has any questions or wants to discuss something, they can unmute themselves and maybe we can have a discussion. Are there any questions for any of the speakers? Please unmute yourself if anyone has any question.
Dr. Pranav.
Yes, sir.
Thank you for elaborating our guidelines. There was a discussion also going on with somebody else in my own place regarding these ECG changes and X-rays.
Yes,
Now,
sir.
since that curve is shifted toward left about the cardiac cases, maybe we have seen deaths at the 25 to 35 years of age. So many deaths we have seen, sudden death, 40 years sudden death, 42 years sudden death. So many deaths we have seen. In the marathon also, Mumbai marathon, you must have seen so many deaths. That means they cannot tolerate those things. Now, ECG, valid for 12 months. I think we have to change that. Because within 1 month you can see changes. I will give you my example. I ran a marathon on 12th of December, and 31st December I was having chest pain. So that means it's exercise or something, or the age is not a factor here. After COVID, almost everybody is having some change in the lungs also, and how they really behave. The lungs, the dynamics, the parameters, how they really behave under anesthesia, whether for minor, for intermediate, or major surgeries. These are very difficult to define nowadays. I think in the court of law also, if we go, since after the COVID, things have to change. We have to modify these investigations. The period is validity. I think somebody coming with you, you may correlate with the history that the patient is not having any breathing problem or any cardiac history, or FRC is good. But there are so many cases we have seen the coronary getting blocked up to 90%. They may not show any symptom in normal life, but suddenly under stress, they become, altogether symptomatic. And that also throws a question about the echo. Are the anesthesiologists competent enough to order for echo? That's another question I think we have to put in our guidelines. Now, echo is a basic guideline, very basic investigation. I think in the next revisions of these things, we have to see in the light of evidence through globally as well as through our Indian database that the investigation parameters have to be changed considering these changes over the last 5-6 years we have seen, rather than lamenting later on that why we didn't do those things. We have seen many patients suddenly developing the arrhythmias, the young patients, and they may ECG may be normal. So I think we have to see in the light of evidence the new changes in these type of things. I think these were made in 2016, and
Sir,
almost
2022.
and in between,
22.
no.
Pre-COVID.
See, it first was made in 16. Then we came for the minimum mandatory guidelines. I'm talking about ISA.
Yes, sir.
Then we have to change it, revise it. Now we released last year. So I think this type of seminars, webinars are very important to see the changes, to see the progress we have made. And I think in the light of that, we also have to undergo revision. But anyway, it was a wonderful elaboration of the guidelines. And you in a private practice still had a time to prepare such elaborately. That's a really remarkable. Thank you for that, Dr. Pranav.
Thank you, sir. Thank you, sir. And sir, also blood sugar monitoring is not recommended in these guidelines, even for minor, intermediate, or major surgery. So any patient may be having diabetes.
Yeah,
So
that is a subclinical type of diabetes. I think diagnosed first time on the table sometimes.
sometimes,
So
yes.
that is also true. That's also true. Yeah. We have to see the changes we have to bring in these guidelines. Dr. Arun want to say something?
Sir, about the ECG duration that you said, the validity. So there is a small caveat to it. We have mentioned that the ECG will be valid for 1 year, provided there are no fresh changes or fresh symptoms, not changes, fresh symptoms. Because in a small nursing home, actually getting an ECG itself is a big problem. They have to run to many places because small nursing homes usually don't keep an ECG, or a maternity nursing home may not have an ECG. So I think this is good. I mean, this duration, the validity, I think is good as far as my thoughts goes.
Sir, to be very frank, nowadays we have seen so many places, even the small maternity homes, they are attached with the labs. They carry the portable ECG machines, or they can also keep with themselves. Or many labs are there, sir. They just do it for 50 rupees, 20 to 50 rupees, they do the ECG. I think that is not a costly affair. And having it, and see, 12 years, 12 months. In the court of law, the evidence will come against us by the cardiologist, not by anesthesiologist. It is the cardiologist who will be giving the evidence if something happens like that. Why you didn't do the ECG, although the symptoms were not there, patients were asymptomatic. That's what I'm saying. The sudden collapse under stress is different. Patient may not be having may not be having symptoms.
That means we will have to do ECG even 15 days prior to the surgery. Even if the patient has had a ECG done 1 month back or even 7 days back. So that I mean, we have to define what is our what should be our stand. So if you feel, or if the patient gives the symptoms of change or chest pain or sudden cardiac here, then obviously you have to do a fresh ECG. Is
Sir,
my
I will tell
thoughts.
you just another patient I encountered only 13 days back. Patient had a symptoms of only the backaches, only the backache, and they asked me that we want to show to the orthopedicians. Okay, manager, first of all, I told it may be the sign of the stress of the cardiac tissue. You get a ECG or echo done. And also side by side, because the CP can be and trop T, because he had said that he had certain sweating in the morning for almost 10 minutes, 3 days back. Sir, ECG was normal, echo was normal, and trop I rather, it came out to be 612 with the normal units range up to 10 only, almost 60 times, sir. So that was, I think, diagnostic. And when the angio was done, it was 96% left anterior descending blocked. So I think these type of patients we keep on encountering. So it's always better. I think we define these guidelines in our ISA private practitioner book that at least ECG, sir, should be new, not the 12 months old, so that we will be able to hold our ground whenever the case comes against any of the practitioners. That is my take on these type of things, sir.
Sir, I'll just like to add, actually, I was thinking of raising exactly the same point which you have raised, Bajwa, sir, because I'll tell you my experience. I was in cardiac anesthesia for about 6, 7 years. Then I went back into general anesthesia. But during those 6, 7 years, the kind of patients I got to see, when I was back in general, I mean, working with surgeons and orthopedic surgeons and everybody, I was always on a side of caution. Anybody above 40 would, I would say, please get an echo done. And, people were really annoyed with me. But having seen all those cases, and like you are yourself a cardiac surgeon, so having seen all those cases, I I was just not comfortable with a simple ECG.
Actually, just last week I came across a report where a 7-year-old child underwent angioplasty because of congenital hypercholesterolemia. I mean, all these things are
No,
just
that is
coming up, and
not hypercholesteremia, hyperlipidemia. That's a
lipidemia,
genetic.
sorry, hyperlipidemia.
That's a
Yeah.
common, Dr. Pankaj, that is very common.
Hmm. Hmm.
That's very common. I think she
Yeah.
had a little bit higher cholesterol, and majority of the people who are getting that the coronary blocks are due to the congenital hyperlipidemia nowadays. It's a very common. If you find cholesterol, even with the statins, you may not be able to lower down the cholesterol. I think that is a common thing. But I think for our safety, we have to always modify our guidelines as per the necessity, because the private practitioner, one man army in the periphery, nobody is going to protect them tomorrow if something happens like that. ISA additional statement may not be able to guard them properly in the court of law, because the evidence will be given by the other specialist, the medicine specialist or the cardiologist. So I think eco also we should have to bring under our ambit. I think we should not be hesitant enough if we feel that something has to be done. So eco we can always order. I think we have discussed in our practitioner module also that wherever necessity is there, eco should be done at least to medico-legal purpose, not just for the management of the anesthesia. So we have to safeguard. It's not just that the cost will be adding, because that is for the life of the patient. The patient will be having that, you cannot just guide for surgery. For the daily living, for the rest of the life also, patient will be very much aware that he may be developing some disease because of the cardiac ailment. And that will be very helpful for them. This is my take, sir.
Yeah. There's one
Can I
question for
come in?
Dr.
Dr. Pankaj,
Pranav. Yes, sir.
can I?
Of course. I was going to make you the last speaker.
No,
Go
no,
ahead.
actually, I joined a little late.
Right.
Good evening, all. Actually, this discussion about investigations. Previously, when we made the guidelines in 2017 exactly, and they were released in February 2018. The basic purpose was that in Indian scenario, we didn't had any guideline at all. So what was happening was, whenever there was a case in the court, the guidelines from the West were quoted. So our purpose was that the scenario in India is totally different. We cannot have all those monitoring. It's impossible for small places. So that was a basic thing in 2017, prepared and released in 2018. But with the time, we all know, see, on one side, like Dr. Bajwa mentioned about ECG, it's not a question of saving 100 rupees. Just imagine, because whether it is a small place or a small nursing home, or you are working in an institute, if the case goes to court, everyone is equally liable. Even the penalty is also going to be the same. So we have to save ourselves. And as far as the ECG changes and all, so I don't think there is any problem. Every one of us cannot become a cardiologist. We should go for a cardiologist opinion. And invariably, what I have observed is in my city, if you send a patient, if having some symptoms or changes in ECG, they invariably go for echo. I mean, they don't give opinion like that only. That is what I have seen. So we should not hesitate in asking for cardiologist opinion or a echo. Even if we feel a 1-year-old ECG, yes, at a small places, Dr. Nair like mentioned, it is acceptable. But I think for our safety, if there is not much issue, we should go for another ECG. 1 year is a long time. I agree. Anything can change. So it is for our safety purposes. And practically, we have to first save ourselves. Anything happens, nobody is going to say why you saved. You did it for saving 100 rupees or 200 rupees. No one will listen to us.
I'll tell you something about what our position statements have mentioned. See, in private practice, because we are a one-man show, there is always a discussion in most conferences whether do you require a preoperative certificate from the physician or not. In private practice, what we do is, invariably the cardiopulmonary status is mentioned about or looked upon by the physician who also gets an ECG done, and then he decides whether a 2D echo is required or not. There are cases where the 60-year-old and 70-year-old patients have been given ECG clearance on fitness, but the anesthetist has found in the history that patient probably requires a 2D echo. So we get it done. So this is specifically mentioned in the position statement in the initial pages. If you realize that there is no harm in getting a physician fitness for cardiopulmonary status of the patient, not anesthesia fitness. Anesthesia fitness is to be decided by the anesthetist, anesthesiologist, but the cardiopulmonary status can be opined upon by the physician, and it definitely helps, even in another way. Unfortunately, if your patient from the operation table lands up in an ICU, you have a physician to back up to. He can help you, be there to help you and give you an ICU backup. So in all these conferences, I have been trying to suggest that it's no harm in taking a cardiopulmonary status fitness from the physician. Involve a physician, it definitely is useful. In institutes, things are different. In private practice, things are very different. Please, Dr. Katikar.
Yeah, I just wanted to say something that even especially after COVID, we are also getting many young patients with stroke. Even a 7 or 8-year child may come with a stroke. So the pathophysiology for MI and stroke is same. So the hyperlipidemia, hypercholesterolemia. So all these factors has to be taken into consideration whenever we are thinking about including ECG in our preoperative investigations. I remember Dr. Shirolkar sir, who was our head of the department in JJ Hospital, used to say, if whenever we used to go and ask him, sir, can we do echo for this patient? He's 80-year-old. So he used to tell us, the patient has a heart, so definitely do an ECG. And such kind of incidences. I remember one case, a 16-year-old boy was posted for nephrectomy. I entered the operation, this was long back when I entered the operation theater. I thought the ECG was not, of course, done for the 16-year-old boy. And I saw the monitor and I found that there is something abnormal, arrhythmia type picture. So I did an ECG and it turned out to be WPW syndrome. So even we can miss such kind of things if we do not do ECG. So we are just not thinking from MI point of view, but also from arrhythmia point of view, from heart block point of view. We have to do these cases may be anecdotal, they may be, but then we cannot neglect such kind of cases when we are in private practice, because if we induce a WPW syndrome without giving anesthesia, you all know what consequences will happen. And third thing, I echo the whatever Dr. Rajnikant Gajjar sir has written, because these webinars are specially kept by ISA to popularize our ISA position statements, and with the attendance of 45, amongst them almost 8 to 10 are the ISA members, the National Governing Council members and the faculties. The attendance is really low and we need to popularize the attendance. We need to make these webinars, the attendance should improve in these webinars. That's what I feel.
Yeah, perfect. There's a question for Dr. Pranav. When patients are onco patients, even for minor surgery, what ASA classification will be considered? Post chemo, post radiation, difficult intubation cases for lymph node biopsy. Dr. Naina Kulkarni has asked this question.
Sir, we have to do according to the ASA guidelines only. So it is we have to do according to the ASA guidelines, and lymph node biopsy is not a major surgery; it is a minor surgery. So only CBC is required, and no other investigation would be required as such.
Yeah.
Dr. Pranav, I will clarify further.
Yes.
See, any patient coming with the post-radiation, post-chemo, invariably the patient had a disease. So
Mhm.
first of all, they land into ASA2. Okay. Any recurrence or any flare-up of a disease, then land them into ASA3 category. So whatever the person present with, whether the symptoms are there or something are not there, it's a minimum ASA2. If any part of symptom is present, it's ASA3. So that is the way we have to classify these things. Although there may not be exact word-to-word classification of these cases, but you have to take individually each and every case according to the presentation of the symptom when they are presenting for even for minor surgery or even for intermediate surgery or major surgery. That's how the classification goes.
Dr. Bajwa sir, this is what makes the individual discussion very important with the family and the patient. Of course, it's equally true that whether in government hospitals people are very busy and also in the private sector people are busy. And it's not always possible to have a detailed discussion, but then we have to see what is the minimum required.
Yeah, true, absolutely true, because these are very, very important part. A patient, family entirely involved with the surgery. So we may have a difference of opinion even in this webinar, but that doesn't mean we may have individual differences of opinion. But as a whole, we have to see the entire community, entire fraternity of our anesthesiologists. So whenever we are asking for the investigation, that is a must that they should be saved, because anesthesiologists, you people are doing, we are doing rather, the wonderful job, taking all the risk every time, taking the patients, and somehow we are doing for the goodwill, not for the bad way. We are doing for the goodwill, and in that goodwill, if we get entangled or we get crucified, that's also not a good thing. So better to have a safe standard investigation with us, whether we really want them or not, whether we really require them or not. But these basic investigations should be there to protect at every junction. 100 out of 1,000 cases, 999 may go, safe. But in the only one case can always, land you up in trouble, and that it will be a player of so many things. So better to be on a safer side than to feel sorry later on. That's how I think we should be framing the guidelines or revising the guidelines and advisory position statements. I think that's why we kept this position statement discussion, the webinars, in these webinars. I think we are going ahead with revisions also. Dr. Pankaj, I've already told you, keep the record of all the new things which have come for discussion in this webinar. We will be incorporating them.
Like that. What about 6-minute walk test also being included?
See,
Can we all
Dr. Shaljas, 6-minute walk test became very popular during the COVID time. I think it's not a bad idea if you can do it. But in many of the patients coming with the for a surgery, intermediate, minor, or they may not be able to walk. Osteoarthritis may be there. So many things are there. So it's not always feasible. If it's feasible, I think no harm in doing that.
if they can't afford an eco, if it's a lower resource center not affording eco, and it
A
is a
patient,
minor
we can't afford eco. Dr. Shalja, if you ask me honestly, eco, how much it really costs, a surgeon or forget about a surgeon, even a nursing home is of anesthesiologist. He's getting a patient done. Suppose he's taking for 12,000, 15,000 for any minor surgery. Getting a eco done is more safer, decreasing the
Yes, sir.
profit. That is
Yes.
more applicable nowadays with the medical legal things hanging. Every day we are
Yes.
seeing every anesthesiologist approaching the ISA that they have got entangled to this case, how the ISA can help them. I'm
Yes.
not going to reveal anything, but there are incidences happening throughout the country where we are getting the calls, and sometimes individually talking to them really help them. And going forward, we have to respect our fraternity, make it more friendly, make it more awareness about anesthesia to everyone. not to the public, to the surgeons, to the orthopedicians, the gynecologists, that we anesthesiologists are really taking care in all the way, right from the pre-anesthetic checkup to the post-operative care. So I think going with that uh, vision in our mind, a basic investigation are a must for every patient.
In fact, serum creatinine in a minor surgery, I would like to do, even if like, probably if it's a cataract and patient might have CKD and he doesn't give you the symptoms and you have a pulmonary edema on table. I mean, there have been instances like that too. So, I mean, certain things have to be modified. I mean, I'm happy that ISC is coming up with all these, and I hope people read them, people imbibe them into their practice in peripheries. Because in institutions, anyway, there'll be a lot of backup and there'll be people to guide and there'll be teamwork. It's only these individual private practitioners, and that's they are not attending, and that's what I see. There is very less attendance, and it should reach maximum in the interiors of the country.
I definitely agree with you for these things. But I think this is a wonderful platform, and I think this message was sent to across the nation. Every practitioner, they should at least spare time to read the message. I send in the flyer format also, in the message format also. This is for the benefit of the practitioners who cannot spare the time for going to the conferences. At least in these
Yes,
webinars, they can contribute their, wisdom, their experiences here. So many things can be, to at least they contribute to ISA by modifying these guidelines, modifying these position statement, adding to something to this. This is a very much required, I think. So tomorrow,
yes.
everybody say that what ISA is doing for them. Dr. Pankaj, ask Dr. Pankaj, ask Dr. Manisha. Everybody is working hard for these type of things, for the position statements, and coming out with the webinar just to sort out any differences, any difficulties, any challenges. And still, if people don't listen to that or don't contribute to that, that's, I think, a difficult scenario then for our entire governing council to go ahead with the modification and revision in the position statement with the changing times. I think I leave it to Dr. Manisha and Dr. Pankaj to give their opinions. Dr. Bhaskar is also there. Dr. Chauba is also there. See, all the GC members are attending. They have taken a time. Dr. Virendra Sharma is there. So many people are attending from the GC. But out of, I think, how many? 37, almost 7 are GC members.
Any comments from anyone else from the audience? You can unmute yourself and give your 2 words of wisdom to us to find it feasible for us. Dr. Kanjolia is there right from the beginning, I can see. Any comment, Dr. Kanjolia? You can unmute yourself. You can unmute yourself, sir.
Sir, I strongly believe that pre-anesthetic evaluation should be done by anesthetist, and if we allow the physician to do it, to do cardiopulmonary evaluation, then the chances that the anesthetist will be doing it decreases to at least 50%. So,
No, the physician is only going to opine the cardiopulmonary status of the patient.
sir,
Fitness is decided by us.
if the patient goes to physician, then they do not come to us. So
They do
it is
come to
either
us.
we or, but it is not there in the small cities, sir.
No, I agree with Dr. Pranav. What Dr. Pranav wants to say that in the current scenario, in the present day scenario of anesthesiology, we are calling ourselves as a perioperative physicians. What extra we require? If the cardiac symptoms are there, definitely go to the cardiologist rather than there's a physician. When you are saying no physician has ever come in the operation theaters to see how the patient is behaving under stress or anesthesia or under surgery. But definitely cardiologist has a lot of experience. Now, there was a point of discussion regarding that ECG and echo. You go to any center, cardiac center, whenever the echo is done, they always do ECG first. Because in the syllabus of cardiology, when you read the cardiology sciences, you have to correlate the ECG with the echo. The electric access, how it is varying with the echo. So many things are to be seen together. You can't just say that echo is different or ECG is different. They have to be correlated with each other. That is how the science of cardiology is teaching to the cardiologist. So here also I agree with Dr. Pranav, when we are perioperative physicians, definitely I think if you are a good over the time, every practicing anesthesiologist, they have seen so many comorbidities, so many diseases. You should refresh your knowledge also in between. You can be a better physician than the general physician. Except cardiology, there are certain big problems. Definitely, we should not take chance.
Yeah, medico legally, you share responsibilities by having a physician. It makes sense.
So
Dr.
I
Pankaj,
agree with Dr. Pranav, because I work in a optal setup where they insist on a pre-anesthetic evaluation for all patients. Most of the cases are done under topical. So one patient said, I've already undergone a physician fitness. So would I need to do a anesthesia fitness? I said, of course. So she asked me whether you are bigger than the physician. I said, yeah, I am bigger than the physician in the operation theater. So you need to undergo a pre-anesthesia checkup. So like what Dr. Gupta said, that happens many a times. People feel once I've undergone a physician fitness, why do I come to you? So we are defeating the very purpose of all our guidelines about PAE being mandatory.
Dr. Pranav,
It should be the other way around, I feel.
see, I think this is a unnecessary debate. Thing is, when you are doing a pre-anesthetic checkup, now the physician cannot examine your many other issues like the airway or anything else. So
Exactly.
it is not that the physician has given or not, but at the same time, for practitioner's sake, we should not have any ego issue. Now, suppose you have got all the investigations done and all, and you get the X-ray chest and ECG. If you are finding that this patient needs to have a PFT done or something of a chest reference, we should not hesitate. It's okay that we are peri-operative physician, but we cannot replace a cardiologist or a chest physician. So it is a balanced work. And it may be at some places, like you all are saying that everyone goes for a physician fitness. That is the job of the surgeon to recommend, but we are not going to accept his fitness. I think
Sir,
that
but,
the surgeon also knows. That
it
the
is
surgeon
coming up
also knows, because
in
anesthesia is going to be given by us. Let him
Sir,
get a physician opinion, hardly matters for us.
CGHS guidelines also have started saying that physician fitness is required before surgery and not the anesthesia fitness.
No,
So
they can't write not anesthesia fitness. I doubt.
Cardiopulmonary
Sentence
status.
cannot be written that anesthesia
Yes.
fitness is not required. In fact, if you go through all the documents of NABH, WHO recommendation, whatever, everywhere, even the legal, the courts clearly say that before a surgery, a pre-anesthetic checkup has to be done by a qualified anesthesiologist. This is the court ruling in almost all the cases pertaining to
Absolutely.
anesthesia.
Absolutely.
So I doubt anybody can say that anesthesia checkup is not required. I doubt.
There is a
It's
High
not
Court
possible.
ruling which says the ruling went against the surgeon and the anesthesiologist because there was no PAE notes. So the High Court has straight away said that if there are no PAE notes, it is straight away negligence if the patient has a cardiac arrest on table. So without PAE, you just cannot induce any patient. There is
It's
no doubt
mandatory.
about that.
It's
It's
mandatory.
101% mandatory.
No confusion at all. There is no
No
confusion at all.
confusion.
No guidelines can say that
Yes.
pre-anesthesia checkup is not needed. Nobody can say that.
right, sir.
Dr. Amit Kumar has raised his hands.
Yes, sir. Good evening, sir. I am Dr. Amit from Bihar. I'm Associate Professor in Medical College in Bihar, sir. So first of all, I would like to thank ISA for coming up with these guidelines, because we have been showing these guidelines to our surgeon colleagues in our medical college. And in this way, we are somehow being able to convince them regarding the investigations which we are ordering. But sir, in private practice, I'm also doing private practice, sir. But private practice is the biggest fear as a private practitioner is losing a center if you ask for certain investigations. And which I've lost 2 centers because of this, but I'm happy to work on my terms, sir.
This is a little drawback of private practice. You have to
Yes,
decide with whom you want to work and with whom you don't want to work.
yes,
In fact,
yes, sir.
the sooner in life when you learn to say no to a surgeon, the happier you are as an anesthesiologist. Your blood pressure and everything remains fine. I am 60 and till I'm not on any medication, unlike most of my colleague friends. So learn to say no early in life, you will be happy.
Yes, sir. Yes, sir. Thank you, sir.
Dr. Rajiv Gupta, I can just see you online. Unmute yourself, sir.
Good evening, everyone.
Good evening. Any comments, any suggestions, any discussions, or we can call it a day?
Yeah, this is something good that we have kept a webinar for the private practitioners. And here we are discussing various problems which our colleagues are facing. And absolutely right, you said that you should know where to say no. And it would be very good for everyone if they are working on their own terms and conditions. No matter if you lose few of your centers, but
No problem.
peace of mind is something which you can never achieve with money. So my
Exactly.
take is be happy with little, but you have to be very cautious about your practice and your subject because observation and quick decision is must in our practice, which is required at the most. So that is all what I can say about it.
Thank you, sir. Any concluding remarks, Dr. Virendra Sharma, Dr. Bajo, sir?
I think
Can call it a day.
discussion is very good.
As
Let
Dr.
Dr.
Manisha
Vrinder say
said,
first. Dr. Vrinder.
it's not a very happy situation to see so less participants. See, the purpose was to make people understand what is there in the position statement and have a discussion. As Dr. Bajwa said, that we have to continuously upgrade ourselves. So we must have a interaction with them that what is the problem? Is there any problem of time or day or whatever it is? But unless majority attend, see, we can keep on trying our efforts, but the benefit has to be passed on only if they come and interact with us. This is too low attendance.
The only thing what I've
So
seen is people do see our videos later on when they are free, probably. The recording is visited more often than the people who are there live. This is just an observation of mine.
Dr. Pankaj, recording of the private practitioner webinar is seen less on the YouTube. If you see, you should also, first of all, you should see how many views are there for the practitioner webinar forum on the YouTube. You will see the views. The idea is we are doing our efforts, we will keep doing it. It doesn't matter if the people are not joining that we will stop doing these efforts. Efforts will be done by the ISA. Nobody
Right.
can say that what ISA is doing for the practitioners. I think, for the last 2.5 years, we are doing excellent before, taking off from where the platform was set by the previous concepts.
Yeah.
So we have done a mess,
Perfect.
and in the coming days also we will keep doing it. I think
Perfect.
awareness has to be brought in the minds of the practicing anesthesiologists to attend to these webinars, because these are not costing you any money. They are not giving your practice a miss. They are not causing you any traveling expenses or something like that. You are there.
Yeah.
It's everybody, almost every experienced person is there. You listen to them. You gain something from them. I think that's a worth viewing and worth discussing also. That's what I can say about this. So ISA will keep on doing this good efforts for the practitioners.
Perfect. You'll call it a day?
I think it's better.
Sure.
Yeah. Thank you. Thank you. Thank you, everyone. We had a good discussion. 4 speakers were excellent. Little glitches with Marissa's presentations. Sorry about that, but I feel the overall discussion and the question answers that were discussion was really good and fruitful. And if people see the recording, they will benefit from it. Thank you. Thanks a lot, everyone. Long live
So
ISA.
long live